Hello and good day. Thank you for allowing my team to come in and share with you our thoughts of the suicide of the nation. In adolescents aged 10 to 19, suicide is the third leading cause of death. There's things we can do about this. We want your help and your team to collaborate with ours to propose a strategy that's based towards the World Health Organization's Millennium Developmental Goal number 4. So as your team and my team collaborate, my team is going to provide a suicide prevention toolkit model and monitoring surveillance system as an intervention in communities nationwide. We're going to go based upon the Millennium Developmental Goal number 4, which is to reduce MPH disparities by 2/3 by 2018. So by reducing teen suicide rates, the country would have less health expenditures and the quality of one's lifespan could actually benefit society. So we're going to look at program components such as activities, inputs, outputs, short-term outcomes, medium-term outcomes, long-term outcomes. We're going to ask that schools are engaging in this, that the communities are willing to delegate and pass out the surveys, collect the surveys. We're looking for cooperation and accountability, and we need your help with your team and my team so that we can go ahead and reduce teen suicide rates nationwide. Our choice is to use the social ecological model for looking at each level of where we can intervene. If we look at the individual level, we will be looking at the agent, host, and environment. An example for an agent would be the teen or adolescent. The host would be depression and bullying, etc. And the environment would be something that's promising for nothing but suicide, whether it's isolationism or unaware family members and friends. And that's what we want to do, is bring awareness. So our researchers and epidemiologists are going to look at it at an individual level. When we take a look at it at the interpersonal level, we're going to look at it as we're going out into society and we're making sure that healthcare providers and community healthcare workers have the proper support, resources, and education in order to identify signs and symptoms that are associated with suicide. We need to pay more attention to our adolescent and teen community. I know that cellular devices are a huge thing with teens these days, which it wasn't when I was growing up. I'm a little bit more old school. But these days, teens have so much access to things on the internet that are rendering their thoughts, and it's becoming a reality for them. And they're gearing their life around these things that they see on the internet, which are unmonitored, and we can't do anything about that. Um, so as we progress, we need to make sure that we have reminders out there, making appointments. When we're talking to the teens in the community, we need to reassure that our clinicians are asking questions and observing behaviors. It's really hard to do that when you're in the clinic setting rather than a home setting, but if we have these signs that we can look for, then I think that we can move forward and actually intervene and give some type of help along those lines. Okay, and when we look at the organizational level, we're going to look at accountability factors and surveillance factors and monitoring and the collection of data and the accountability of the data, how credible is the data. So that's where we're really focusing on our communities to encourage the support, funding, and delegation of the self-reported questionnaires that we either send out and or the questionnaires and surveys to the communities and the schools. We need to create collaborative work sites so that we can go out into the community and give public health interventions and try and reduce stigmas and actually go out into the community and allow the teens and adolescents to become involved and feel like it's good to participate and feel like they're helping and that they mean something in the community and that it's normal if you have these thoughts, but nobody ever goes through with it. So that's where we're going to be at the organizational level. And just to overview the community level, we are looking at things such as support stakeholders, collaboration between agencies, interagency, and funding as well as a key component here in the community level. We asked ourselves what makes this the primary issue. Each day in the United States, there are an average of over 5,240 attempts of suicide by young people grades 7 to 12. 4 out of 5 teens who attempt suicide have or will give warning signs that peers, relatives, friends, and family should be aware of. Lack of awareness and education is disseminated throughout our nation. The lack of acceptance to learn this type of information is a negative stigma barrier that we need to break through. And we struggle with that daily because if people think that they have some type of mental illness or they are a problem or they're an outcast, then they're going to associate a stigma with suicide and they're not going to tell anybody, they're going to isolate. So we need to break that barrier. So as we look at a proposal for our intervention, we're going to look at a hypothesis, and that states the teen suicide rate in the United States of America will decline by the year 2019. And then we have a goal, which is to approach at the community level and organizational level in order to implement strategic interventions nationwide. Our team has created a data collection questionnaire. This data collection questionnaire will be given to high schools nationwide and community health centers. 1. Have you ever thought about or attempted suicide? 2. On a scale from 1 to 10, 10 being the best, how would you rate your quality of life compared to your peers? 3. Do you get the most of your information from the internet? The reason we are implementing question number 3 is for our sake to know how much the internet impacts the quality of life of our adolescent population. One of the resources that will take up most time and effort is the community educator training. There's 2 courses that the community educator needs to take. One is the CET 001 and CET 002. We'll have resource implementation such as flyers, commercials, media, social media, and verbal dissemination. Interagency and intra-agency communications in organizations is a must. Organizing community groups, keeping up with the monitoring and surveillance of community groups, and health educators assuring proper dissemination of information to community demographics. the questionnaires have been collected through all the communities nationwide, we will then use a bar chart to compare data. We will compare data from females aged 10 to 15 to males aged 10 to 15 and females aged 11 to 19 and males aged 11 to 19. We will compare in categories such as suicidal thoughts, internet usage, and quality of life. The research used in the toolkit is evidence-based, meaning it's already been proven to work before to reduce suicide rates. So when we educate our community educators, we are using high quality accredited evidence that actually works. Upon the start of our intervention with the experimental intervention group, we need to pay attention to our intervention dissemination. Plain language is a must. What we mean by that is that we want to capture the attention of the audience that we're trying to get. So we need to make something either sound exciting or make it business-like. Whatever your audience is, you need to adapt that so that it captures their specific attention. Plain language is an example of taking the larger vocabulary words that teenager may not understand and putting it into teenagers' vocab so that they can understand it and so that it's attractive to them. After the surveys have been submitted, we'll look at the data and we'll take eligible participants selected at random and we'll put them in control groups, which will receive no treatment, and we'll put them in the experimental intervention group, which will receive treatment. At the end of this, we will go ahead and compare the results. After comparing the data, we need to be sure to calculate the margin of error. This is the point estimate of the confidence interval. The higher the confidence interval, the less margin of error, which makes the result more valid and credible. So what does the data show? Did the intervention work on the experimental trial group? Was the question asked about internet usage useful to our data? Are we collecting data annually or biannually? For this project, we're going to be collecting it annually, just so that we can keep more information. That does not mean that we're ending our trial on the annual date. It just means that we're recording that information. So we are asking you to help us in reducing teen suicide rates nationwide.